Welcome, everyone. We'll get started in just a minute as soon as the room fills up. Okay, I see there's still people trickling in, but I'm going to go ahead and get us started so we don't waste any time here. My name is Christian Ramers, infectious disease doctor here in San Diego. And on behalf of the faculty and staff of the Long COVID and Fatiguing Illness Recovery Program, I'm very excited to welcome you to our third monthly webinar series. We have a great talk today. We're going to focus in on pulmonary manifestations of COVID and of long COVID itself. We have a plan for about a half an hour of a didactic and then a half an hour of good discussion, and we welcome your comments and questions. My colleague Bruce Strumminger from the University of New Mexico and Project ECHO will give us a couple of introductory notes, and then we'll get started.
Thank you, Christian, and welcome everyone. As Christian said, I'm Bruce Strumminger. I'm a professor of medicine at University of New Mexico. Thanks for joining us today for this Long COVID and Fatiguing Illness Recovery Program webinar. Just going to run through a few key logistics. First, we really look forward to your questions and comments. Please put those in the Q&A feature at the bottom right of the Zoom toolbar. We'll be both responding to questions and comments in writing and hope to address a number of them in discussion. If you have any technical or logistic issues, mention those in the chat. We'll try to help you out as best we can. We are recording today's session as this whole series is recorded, and we're archiving the recordings, and your attendance is consent to be recorded. So thank you for that. People ask about the presentations and how to get them. We'll be, hopefully they're linked to today's announcement, but they'll also be available on our website, and we'll share a link to that, the website that supports this series. We're offering CME and other CE today, and about 15 minutes before the end of the session, we'll share a link to a brief survey. We really appreciate your feedback on how the series is going, and that helps us with quality improvement and planning for future sessions. So please take advantage of that. Even if you don't want the CE, please give us your feedback. Just a reminder to keep these sessions apolitical and non-commercial. Thanks for that. And just want to remind everyone that these sessions, these learning sessions, are primarily directed toward primary care clinicians and patient management. We do realize we have a lot of people who are living with long COVID who are joining us, and we're really glad you're here. But our focus will be primarily supporting the clinicians taking care of long COVID patients. Just a note about data use. When you register, when you put questions in the Q&A, all that data we steward very carefully, and just want everyone to know it's de-identified when we're making summary reports, etc. Just want to quickly go through the agenda. I'm going to be introducing Dr. Marilyn Glassberg in just a moment, and she'll be giving a presentation on pulmonary manifestations of post-COVID conditions. That's going to be about 30 minutes. We're then going to have about 25 minutes of Q&A, and then we'll close out. So really looking forward to that, and just want to give people a preview of upcoming sessions. In April, we'll be focusing on autonomic and cardiac manifestations of post-COVID conditions, in May on the history of ME/CFS, and in June on ME/CFS from a patient perspective. So we hope you'll join us for those as well. So with that, it's really my pleasure to introduce Dr. Marilyn Glassberg. Dr. Glassberg is the Division Chief of Pulmonary Medicine, Critical Care and Sleep Medicine at the University of Arizona right now. But in July, she's going to become the Chair of Medicine at Loyola School of Medicine in Chicago. So Marilyn, over to you.
Okay, let's see how this, so I think I should be able to see these slides, right? Can you all see my screen?
Not quite yet, Marilyn.
Okay, hold on. Hold on 1 minute here. Let's see here. We had this all. Okay, here we go. This should work. How's that?
Great, just a presentation view would be great.
Yep, we're good to go. Great. Okay, so let's go back. Somehow it got moved to a slide. Okay. Welcome, everyone. I hope we're going to have a good time today looking at some cases that we've been putting together, some of the work that we've published and some of the work that's going forward as part of the NIH Recover grant that we received along with 3 other institutions. So the focus today is really on the lung. My pulmonary colleagues online, I hope we'll have some good times at the end and compare our notes. So we've come a long way from understanding what looked like from way back when in January of 2020 in terms of what we had with COVID. At about 2 months after this, I had some medical students sort of look up what was the pulmonary realm of disease and past viral infections, because immediately people started talking about, oh no, there's going to be so much that's going to go on in the lung. And in the beginning, we really didn't think there was too much. We thought that this was not going to be the long haul or the long haulers, as we've known to know a group of patients when we initially started. So it was a novel human virus. Yes, it was a new strain. And then we got, more common than just the common cold. Indeed, that is. We've had millions of patients now with this. And I'm going to share with you some of what we've learned or what we're trying to learn about COVID-19 associated lung disease. So we know that there are patients at risk. Certainly patients with pre-existing lung disease can have an exacerbation of their underlying lung disease by acute COVID-19 infection. And we know that from other infections that these patients get. And we can see that with flares, with ground glass, the fluffy infiltrates on the scans and other, infections that they get. We know that it can lead to ARDS and ALI with hypoxic failure. We've all taken care of these patients, seen them in the hospital for months. We also have non-critically ill acute COVID-19 ending up with residual changes on the films. And I'll try to highlight some of that, but here's the problem. The evidence is mostly observational. So what we're looking at, we will look at for a very long time and have lots of retrospective studies. And hopefully we'll get some prospective data from these NIH grants that are trying to enroll acute COVID patients. But as of today at Loyola, where I will go in July, they have actually no COVID in the hospital today. So when we think about trying to collect this data, we get a little nervous that we may not be able to have the prospective work that we'd like to be able to be prepared for the next pandemic. But the trend seems to be about 3.6% of patients 6 weeks after COVID can have persistent imaging abnormalities if we look based on the Chinese data. And I've tried to include the references at the bottom for some of the papers that I think are particularly good at looking at these questions. What's the long COVID data there? That's different, right? About 40% of those patients will have persistent physiologic, functional, or imaging impairment beyond the 2 months of initial infection. Most people have come to look at long COVID as between 2 and 3 months after the residual that patients continue to have some symptoms associated with their COVID disease. So COVID-19 in the lung looks like other lung diseases, right? This is actually a patient that has idiopathic pulmonary fibrosis. And many of you listening know that I've spent my career studying these patients. And you can see sort of this peripheral honeycombing of the disease with some traction bronchiectasis. I don't know if you can see my pointer, but sort of the railroad tracks at the bottom and really sort of the central sparing. And this disease gets worse as it gets to the bases. And there's some overlap, although we haven't seen, although reported, that some of these long COVID patients can develop honeycombing, and we can talk about that in the discussion section. So I show you up at the top, then the patient with IPF, and then 2 patients with COVID disease in this slide. One with the white fluffy stuff looking very characteristic of COVID disease. And then on the other side, a much more aggressive disease with organization, honeycombing, severe traction bronchiectasis. This patient was a respiratory cripple. So there's quite a spectrum of what these patients will end up doing with their lung disease. What we do know is that we can look at this in terms of lung function and know that the most reliable, I would say, and common respiratory function abnormality at 6 months post-COVID seems to be a reduced DLCO. That diffusion is related to a lot of where the disease goes. And I mentioned when I talked about IPF that the disease of the bases is the most compromising for oxygen, and that has to relate to the ventilation perfusion zones in the lung. And it's no surprise then that we're seeing patients on chronic oxygen and maybe oxygen for a very long time. And we can talk about the role of rehab and the development of pulmonary hypertension, I think, in the discussion section. I include this because we're going to talk a little bit about treatment. I think we're all very familiar with the positive recovery study. I won't go through this in great deal except to say that steroids work. There were some problems with the study. The age distribution favored patients under the age of 70, mechanically ventilated patients, whether or not there was a survival benefit if they were greater than 80. Pulse steroids, it didn't seem to have much to do and get more fungal infections. And so we're left with a study that told us to use steroids, but we don't have any standardized criteria for oxygen. And I'm going to talk about the fact that we don't have a study now that tells us randomized double blind that using steroids in the long COVID could be beneficial, but we have a lot of anecdotal reports that potentially the steroids could look like this plot, right, where it clearly favored the steroids versus no steroids in the RECOVER trial. So let's start looking at a few patients and look at the spectrum of this disease. This is patient one. In many of these patients, we were fortunate enough to have some pre-COVID CTs. So we can see that in this patient, I'll show you, that there isn't really striking interstitial lung disease in this. But this patient then at the admission CT on the 5th of January, you start to see what that patient looks like. And that's known now as what we consider sort of the classic COVID CT scan. So fluffy infiltrates, doesn't really prefer one area of the lung or another. And that's what that patient looked like. That patient went on to recover and be discharged from the hospital. Let's see if this is going to advance. Hold on. So the question became, I think, as we saw, and we started to see patients with more persistent patterns of interstitial disease, where would we fit them on this chart of diffuse parenchymal disease, right? So we put the ground glass infiltrates in here, and we're all familiar with some of these patients, certainly in this last category, other forms of DPILD showing up with ground glass opacities, which seem to be the predominant problem. We know from respiratory bronchiolitis ILD, noticed in this chart, smoking related diseases that can also show up with those ground glass opacities. Non-specific interstitial pneumonia, we see that with autoimmune lung disease and viral disease. These patients didn't really have a specific pattern except to say that they were fitting into the chart somewhere, but where? And so we asked way back when, where will COVID fit? Will there be patients that had prolonged disease? And a group in Europe wrote a paper, Peter George and all, that we needed to start thinking about antifibrotics. I wrote back with actually a fellow and 2 medical students that I stuck on the task. Was there evidence that these patients would have chronic lung disease, particularly chronic fibrotic lung disease? We couldn't find it in the history, Ebola, MERS, but it was certainly looming in everybody's mind. And it was looming because we know that the sort of looking at interstitial lung disease, whether we look in broad definitions or others of IPF, in terms of more inclusion, that mortality rate has been going up. And this is from the CDC mortality database that a medical student who's now at MGH is a second-year resident who I'm trying to convince to do pulmonary, showed in a very nice paper this positive temporal trend from 2000 to 2017, higher rates among males, American Indians, and those in the older age groups. Well, we all know that the American Indians or the Navajo, certainly in Arizona, and I know in New Mexico, were hit very hard from COVID. And so this kind of graph started to make us wonder if they were going to fall in here too. with more disease. So let's look at patient 2. Patient 2 is a 69-year-old male who has type 2 diabetes, hyperlipidemia, obesity, undetectable HIV viral load, and was not on treatment, who presented to the emergency department with increased shortness of breath. He was hypoxic in the 80s on room air. And this is what he looked like when he came. This is 1 year prior to the COVID-19 admission. Looks pretty good. But now look at him. This is now contrast CT on admission for shortness of breath 1 year later. You start to see a lot of these persistent opacities with, once again, HIV viral load non-detectable, but documented COVID admission. So this is now what he looked like. If you go back, if you remember the plain CT, this is 10 weeks after discharge, where he has these persistent ground glass opacities. He did have a documented PE on his admission for which he was treated. And he was, this is January 2021. So January 2021, we sort of had decided, I think at that point, that we weren't going to empirically anticoagulate these patients, but we were all seeing patients that were coming in with a vasculopathy, whether it was pulmonary emboli, it was myocardial infarction, it was DVT. And when this gentleman came in, he was, that was considered for him. Obviously, the documentation of P had him treated. He also is noted, as I've said in the narrative, that he had a pericardial effusion. Patient went on, did well, but just to show you the spectrum of disease in this at-risk individual. Patient 3, 76-year-old male, multivessel coronary disease, Stas post PCI, AFib, ischemic cardiomyopathy, type 2 diabetes, comes in, fever, chill, shortness of breath, satting not well, 92% on 5 liters. And what did he look like? So this is at the time of admission. And so this patient too has the ground glass, but it's much more organized in areas. And he starts to have disease sort of throughout. Goes through pretty quickly. You have to follow. I'm going to play it a couple of times so you can see it. But really some concern for an organizing process. You can see him. And then this is 8 weeks after discharge. So 8 weeks after discharge, he's in clinic. He's complaining of dyspnea on exertion, a cough. He doesn't require O2. A 6-minute walk test was excellent. But his PFTs, as you can see here, he has not very significant impairment. He's actually pretty good. So what's causing his persistent dyspnea on exertion? He seems to have some mild fibrotic changes in his lungs, but really remarkably improved from the previous scan that I showed you. And that's really important, right? So if we're going to ascribe fibrotic lung disease, I think all of us on the call as pulmonologists, we wouldn't say that that's a curative process, right? And so I think what's come up and we can talk about is the labeling of these patients with fibrosis, or is it mostly reticular changes? Because in the lung, it's not really thought that you can recover from fibrosis. And lots of us have worked on this to try to make the lung more like the liver in a sense, to create the lung to learn how to regenerate. But clearly this is a patient who improved that had in areas, as I showed you, quite an organizing process. So when we started to see these patients with all this vasculopathy going on, because I'm in the Banner system, and which has access to tremendous amounts of patient data, I just show you sort of a flow sheet of what we started out with when we had over 7,000 scans of patients, and this was 6 months into the pandemic. We looked at those scans. We wanted to only really focus on the ones that were done within 24 hours, that were thin scans, so that we could try to create an algorithm to understand for patient 3, could it be that the patient with the persistent dyspnea on exertion has an underlying vasculopathy? Is there some chronic endothelial damage that results from this? This has been entertained by many people, but could we develop an algorithm using the CT scan to help us understand that? And so this was how we ended up starting out with all the scans, selecting out, and then also looking at patients who had come in at the same time but did not have COVID, who also had pneumonias. And we published this in the ERJ, the European Respiratory Journal, looking at regional blood vessel volumes. And I think just by color alone, and I'll explain the colors in a minute, you can see the marked contrast to the COVID-19 positive patient. And so this is done where we looked at cross-sectional areas, from a small area to a bigger area. And really the compromise is in these blue vessels that you see. And I'm going to show you in a few slides ahead what it looks like for long COVID. And maybe we can start to understand what that chronic shortness of breath, some of the recruitment cough that we think is going on may be attributable to. So the small blood vessels appear to be much less prevalent compared to the healthy guy on the left and the COVID-19 negative woman on the right. And we believe this might be due, as I said, endothelial damage, chronic vasoconstriction of small vessels, and occlusion. We were able to show that this index could predict outcomes in the COVID-19 disease. But remember, it's a large number of patients, but it's a retrospective study. So we showed a mortality difference, as you can see by the p-values, an intubation difference of who got intubated, and then mortality or intubation. This was very interesting to us and has led to the prospective study that we've just submitted for review. But I'm going to show you just a preview of what some of that data might look like. But if we want to define PASC, and this is the basis for the NIH big effort with the PASC grant, we're looking at patients who have dyspnea, decreased exercise capacity, and hypoxia as the most persistent symptoms and signs. They may have a reduced DLCO, not severely, but some of them will. They have restrictive pulmonary physiology, although they can also have normal, like I showed you. And they can have persistent ground glass opacities. They can have improvement in the ground glass opacities. They can have what we're labeling as fibrotic changes that I think are more reticular and potentially reversible in follow-up of COVID-19 survivors. Although I do agree that, and we can talk about it, there are some that seem to be ending up with chronic disease. We need to understand more about them. The assessment of progression or recovery from the pulmonary disease and the impairment in function is going to be very much tied to the use of home pulse oximetry, 6-minute walk test data, pulmonary function test, thin cut high-res CT, so we can really evaluate the interstitial disease, pulmonary angiograms where indicated, and close follow-up. And long COVID clinics, as many of us have established, are really key to this. I refer to you, I think we've talked about this paper before, Nalbandian's paper in Nature Medicine, that I still think is one of the best reviews that's been written. And in that paper, there's this lovely graph of what patients will look like. And we're just going to focus on the very right side of this, where the patient may be PCR negative, but still having symptoms into week 12, 6 months, and now, of course, we know into years. So this is really the past, the post-acute COVID-19 that we're really trying to better understand who these patients are. I think we have a good grasp on the left side as long as our testing works, but on the right side of this, we have a long way to go to really understand what's going to happen to them. So in that paper, the proposal was these COVID-19 clinics, that the early follow-up with all of the sort of end organ damage that had been done with specialists in those areas was important, as well as close follow-up from primary care, consideration for early rehab, education, enrollment in clinical research studies. I know a few of us have ongoing studies, which I hope we will encourage to get patients in, because that's going to be the most help, I think, for us. And then the patient advocacy groups, where we can also capture data on how patients are doing. So they may not have a physical impairment, but it would be important for us to capture the quality of life data as well. So I'm going to show you patient 4 now. Once again, a guy that had a lot of trouble, right? Diffuse airspace, pneumothorax, multiple complications, multiple chest tubes. And you can see his plain film on the left, and then on the right, here's the scan. Really not looking very good at all, very diffuse disease, but then notice the organizational disease in the bases. And I think lots of us feel that organizational stuff is a risk factor for what comes on in terms of the number of people that are developing long-term disease and the clearance of that. At one point in time, I think a lot of patients were getting coverage for community-acquired pneumonia. A lot was written in the infectious disease literature that didn't need to be done. These patients just had COVID. But all of us looking at these films would say, wow, this really looks like it's pneumonia, right? It's got air bronchograms, it's consolidated, patients febrile, patients hypoxic. It looks like that. And that was a harbinger for what was going to come. So this is the patient 26 days after extubation, for very similar as the patient I just showed you. And you can see that this gentleman has persistent findings here on the film with persistent failure. And then last, I'm going to show you another patient with organizational changes from ARDS. This is from February to the end of March. This is last year. You can see really, really diffuse disease, organizational disease, significant air bronchograms. I mean, how would you think, looking at that, you'd be pretty worried whether the patient was going to recover or not. And then you take a look now, well, at March 28th. And this patient, I think, does have some residual changes that we would be consistent with fibrosis, and a lot of architectural distortion. You can see with the cyst formations that are of concern as this gentleman, this wasn't an old patient at all, has to live out the rest of their life. And that was, resulting in the pneumothoraces and intubation. So if we fast forward a little bit to now looking at probably close to about 10,000 CT scans, and now looking at the long-term COVID group, which is about 4,000 patients, what you can see is that the patients look like the vasculopathy is getting better. There's still not as much of the healthy lung on the left, and they certainly don't look as bad as what I showed you from the acute COVID-19 lung. That also looks like in that group that there was some loss of volume, and these are corrected for volume. The middle person here with long COVID still looks like there's some impairment. And so we're wondering whether how long and how extensive this problem will be. And as I said, I think we can only do this by following these patients for a while. So in summary, then, I think the establishment of long-term COVID recovery clinics will provide immensely valuable data for us to understand the clinical course and how much reversibility is there. The fibrotic changes that we're calling fibrotic include traction bronchiectasis and reticular changes. And whether or not permanent honeycombing develops, I think is unclear, but there certainly does seem to be a segment now that is developing that and will be written about. These patients do end up with tracheostomies. We've had a few now do very well with the closure of the tracheostomy and doing okay, and not having chronic oxygen therapy. And is there a role for antifibrotic therapy? This is the subject of a current trial being conducted by Boehringer. Looking at it, we are looking at the scans with the algorithm to see what we see in terms of chronic vasculopathy. I think it will be very interesting. It's a broad spectrum of patients, mostly based in the Northeast. And whether or not we should use steroids for when these patients flare, I think this is a really important question that we don't have randomized double-blind trial for, to my knowledge. And that's a problem, because we're going to come back and say, oh, well, I gave that patient a short course of steroids and, that organizing pneumonia just cleared up right away. And we won't know then if it was going to clear on its own, if there's an ability for the lung actually to recover at this point, or if we actually have to treat them. And most importantly, I think there is a role for lung transplant. Many of us have had patients transplanted now for chronic COVID-19 respiratory impairment, and they're doing well. But I think when they have refractory respiratory failure, this is something we have to consider, especially when it doesn't look to be responsive and they're within the age group to get transplanted. So America's biggest health crisis, yes. I think we still are really concerned about the fact that we know now that long COVID's not rare. It's a crisis. We're trying to understand it, but now we're not going to have new COVID patients to follow to understand. I think that it's not the pandemic part of it. It's more about finding out what happens to them over the long term. So I'm going to stop and be happy to take your questions. Thank you very much.
Marilyn, thank you for a really great and rapid review and for sharing lots of scans. We're going to talk about that later. I think what I'll do now is actually introduce our panel. I do have some questions for you, Marilyn, but why don't we bring everybody else into the conversation first? And to the participants, almost 500 of you, thank you so much for being here. Feel free to share links or things that you think other people would benefit from in the chat. And then we have a Q&A box, which is already starting to light up even more. But let me get to our panel. I feel like there's a joke here somewhere about what happens when you put 4 pulmonologists, a cardiologist, and a patient expert in a room together, but we'll find out, I guess. I'm really happy to introduce Michelle Harkins, who's Professor and Chief of Pulmonary and Critical Care and Sleep Medicine at the University of New Mexico. Welcome, Michelle. We have Jason Maley, who's an instructor at Harvard Medical School and the director of the Critical Illness and COVID-19 Survivorship Program, and Director of Quality in the Division of Pulmonary Critical Care and Sleep Medicine at Beth Israel Deaconess. Welcome, Jason. Molly Billings is an Associate Professor at Division of Pulmonary Critical Care and Sleep Medicine at the University of Washington and the Medical Director of the Chest Clinic at Harborview Medical Center. We have Jeffrey Hsu, who's an Assistant Professor, Division of Cardiology at UCLA and the founder and director of the COVID Cardiology Program at UCLA. And Sonak Pastakia is a pharmacist and professor of pharmacy practice and a person with lived experience from Purdue University for Health Equity and Innovation. So welcome to all of you. I want to start actually, Marilyn, with you. Lots of pictures in your presentations. I was trying to think of how many patients I had that looked similar to your patients 1, 2, and 3. Some of them, though, have post scans that really look relatively normal. And yet still have very persistent symptoms. So my first question for you is, are we sending the right tests right now? Are we going to find things on more sophisticated testing like MRIs or some of the blood vessel scans that you showed there? Are we looking in the right place right now?
That's a great question. So part of the PASS grant actually puts patients in 3 tiers and tries to address what you're asking, Christian, about what their symptoms are really about. So tier 1, they have a series of what we would all call routine tests. Tier 2 separates them out so that some of them will get CPET, some of them would get echoes, they get more advanced studies, and to Jeffrey, really looking at whether or not a lot of their dyspnea is coming from other reasons besides their lung, especially when the scan's clear. I think I still believe that a lot of it, and I'll be interested in my other pulmonary colleagues and what they have to say, but we believe that some of this is some very small vessel disease and that it's persistent. And there is a trial, or there are a couple of trials, anticoagulating patients that we're going to see if the metrics that are measured, the outcomes, help us look at that chronic dyspnea. I am struck by the number of patients who still complain. We get a lot of patients coming into the long COVID clinic who actually have normal chest x-rays. They've had workups from the cardiac side that, although preliminary, I think it was what Jeffrey might say, I think they will benefit from this tiered approach. Tier 3 takes them all the way to caths, et cetera, invasive studies, and some very sophisticated CPET work and cath combined to try to figure out what that dyspnea is about. And I think we don't have an answer right now to what I don't think these patients are making it up. We just can't document it. They don't desaturate on a walk test. They don't do any of the normal things we're all looking for. So I think that if we can get enough patients enrolled in that PASS recovery study and in clinics, in these COVID clinics, I think that will be helpful. But I'd be interested in what my colleagues have to say as well.
Yeah, thanks. I want to bring Jason and Michelle and Molly into this because there was a question that came up in the Q&A, which is something we see all the time. And it comes from Marissa saying, I've heard of lots of patients that still have trouble breathing and still have dyspnea, but have these normal lung scans. And there's an interesting description in the rest of her question about there being something wrong with the diaphragm or maybe the nerves. And I know, Jason, you've talked about this before. Is there something else going on here with the neuropathy or the autonomic nervous system?
Yeah, thanks, Christian. So one group of patients that we've seen commonly include people who say they're very short of breath, even just talking to you during your clinic visit. And that's separate from people who have shortness of breath that comes on with exercise. And that struck us as a pretty large group of people who feel like they can't take a full satisfying breath just sitting in front of you. And to me, that seemed like it pointed towards the perception and the sensory aspects of breathing more so than cardiopulmonary fitness and some of these other exercise tests that suggest there may be peripheral oxygen utilization issues and other cardiopulmonary issues. But for that large group of people who feel short of breath and can't get a satisfying breath talking to you, we have wondered if, as we see with many other neuropathies in long COVID throughout the body, if there's something neuropathic to this, or if it relates to autonomic neuropathy, which is well known to also have a component of breathing discomfort and shortness of breath with it. So I think that's very possible for this group of people who are feeling breathing discomfort, and yet it's not even with exercise, and it doesn't seem to be associated with a likely cardiopulmonary issue. And then there's the group that Marilyn's been talking about that we need to get to a greater level of detail to understand beyond the standard clinical tests, what's truly going on in the lungs and where might these injuries reside.
Michelle and Molly, anything to add there?
I would agree completely. I see a lot of patients that, you're trying to validate in our minds that they have some pulmonary function abnormality. A 6-minute walk test is different, and their chest x-rays or CTs have actually improved, but yet they're still short of breath. And so is there, is there diaphragm dysfunction? Is there microvascular issues that we're just not seeing on our traditional tests? Or are they, deconditioned? I mean, this was a virus that caused a lot of fatigue and a lot of a whole host of symptoms. And so some may be deconditioning, but I think we just don't know the answer. I think I've been happy that a lot of my patients have actually improved and their scans have improved. So there are the subsets. I was like, let's be patient. Let's give it a little bit more time, and maybe you will have improvement too.
Yeah, I would agree. I've had exactly the same experience where I've looked really hard. We've done cardiopulmonary exercise tests and as well as pulmonary function tests, trying to dig into understand, is this cardiac? Is this my myocardial issue? Or is this some sort of mild asthma that's been triggered? But really nothing has been found. And so we've been stumped. And I agree that our best theories right now are these possible small microclots, as they're known, as possibly causing some, although you'd expect to see, as a pulmonologist, I would expect to see that on the DLCO, but maybe. And then maybe also some issues with the neuromuscular and control regulation of breathing and sensation of breathing is another possibility. But yeah, the good news is it's been long enough now that I have seen these patients that I didn't really know how to help, but when I saw them back, they were better, and I'm not sure why. I wish I could take credit or figure out how to help them, but perhaps it does improve with time.
Thanks to all of you. I want to bring Sanak into the discussion here. While the specialists are sometimes stumped about what's really going on here, we have really a need to do something with our patients and to give people advice. Can you speak a little bit to sort of what is helpful, and even more importantly, what is really not helpful for people that are struggling with fatigue and dyspnea?
Yeah, and I think my comments will reflect one of the questions that was asked in the Q&A about differentiating deconditioning from prolonged hospitalization and all the issues that come along with that from actual sequelae of long COVID. And that's an important distinction, because the treatment strategies for deconditioning is to ramp up activity and start doing graded exercise and start pushing people to get back to normal. Whereas for people who have long COVID and a lot of these other disabilities, the treatment regimen is the exact opposite, where we should really be enforcing and encouraging patients to pace their activity and really be intentional about taking rest. Because if you push yourself too much, that's when you get into a lot of trouble. And even if you look at some of the chat comments and the questions, there's people who are talking about when they start talking a lot, they can't get a breath. It makes them extremely tired. These are all things that are fairly common amongst patients who have long COVID. And my advice from my own experience is to really just stop and start pacing. When you feel like your body is revolting against you and telling you that you're overdoing it, listen to your body and start pacing. And there's a lot of debate on this from past studies that recommended graded exercise therapy for diseases like myalgic encephalomyelitis, chronic fatigue syndrome, and long COVID. All of those studies, for the most part, have been dismissed, and graded exercise therapy is not recommended because it can do more harm than good. So the biggest hallmark that I would mention for treatment is pacing. And there's a lot of details on strategies that you can talk about with that. That's a whole hour-long presentation, but my biggest piece of advice is really pace yourself and limit your activity when you feel your body is revolting against you.
Thanks, Zdenek. I just want to make a comment that there's a lot of interest popping up in the chat and a lot of questions that are a little off topic. We have 3 years to make it through a lot of these things, and we'll have certainly hour-long sessions devoted to treatments and devoted to cardiac manifestations and pediatrics and everything else. We're going to really focus on the lungs for right now and really what's going on. But to get a little off topic, I want to bring Jeff Hsu in the conversation. Montana asked about POTS. My question for you is, are there other things, maybe other autonomic related conditions that can kind of be mimics? If people present with fatigue and dyspnea, should we be thinking of something else on the differential diagnosis?
Yeah, I think is a great question from Montana. I think, and to Sanak's point too, I think it is important to really characterize the symptomatology that is present in the long COVID patient before us, because I think, as we've all seen, it's incredibly heterogeneous. And I don't think there's one specific phenotype. And I do think, at least in my practice, I've just seen different patterns emerge. And I feel like there are clearly different treatment strategies that work better for one type of long COVID patient as opposed to others. With regards to POTS, I do think a lot of symptoms get attributed to POTS, but I think it's important to just remember what the diagnostic criteria is for POTS. I think patients who have orthostatic intolerance, where they stand up and have symptoms, which may include dyspnea, I think some may label them as having POTS, but I do think it's important to understand the tachycardia component, because I do think that it can influence the treatment regimens that we can recommend in this particular subset of patients. But I do think the dyspnea that we see in a lot of our patients too, it can be multifactorial. I do think there is a component of deconditioning, but I think in most of our patients, that's not the sole component. I do think it's really important for us to do the testing to really understand the physiology of the patient before us and which phenotype they may fit most closely within, and that should guide the treatment strategy. Lastly, I just do think that back to orthostatic intolerance, I think I'm just learning more and more. I never quite, before I started this, seeing these long COVID patients, I didn't realize that dyspnea could be such a prominent symptom in orthostatic intolerance, but I'm seeing it quite a bit. And I do think there clearly can be some pulmonary pathology involved with it, but I do think there's some component of the sensory phenomenon that Jason was mentioning, where something is impaired with how we sense our normal breathing, and abnormal function there can lead to the sensation of dyspnea that I think we're seeing in a lot of our patients when they're upright, when they're walking. Yeah, long story short, I think just it's important to do the testing to really understand the physiology of the patient in front of you.
Thanks. I want to come back a little bit more to therapeutics, because I see actually a lot of discussion in the chat about some things. The two easiest at hand are going to be steroids and inhalers. We have a question in here from Katarina talking about, what about people that have pre-existing asthma or pre-existing COPD and are having escalation of their usual inhalers, whether they be bronchodilators or steroids? So let's maybe, Marilyn, start with you on just the utility of traditional medicines that we use, steroids and inhalers. And then maybe I'll bring in the other pulmonologists to talk about other things like hyperbaric oxygen or thromboxane or prostaglandin inhibitors.
Orlando. So for us, we would manage that as an exacerbation of the underlying lung disease and the hyperreactive airway. We've all seen that. The pulmonologists will all nod together that the post-viral, right, Molly? Yeah, the post-viral issues still are managed the same way. And we don't change what we do. So whether that's a short course of steroids or patients who have already been on steroids. You know, we thought those people would be protected from the COVID lung disease. We didn't see that, right? We didn't see that that happened. In fact, some of them seem to even get worse disease. But the hyperreactive airway, so when the pulmonologists are giving the inhalers, the combination inhalers, as well as short course of steroids, and even potentially, you know, if they develop an acute bronchitis, they're going to get treated as such. I don't think there's a specific post-COVID management of somebody who has underlying asthma. It's to treat the underlying disease. And we've seen them flare, you know, they're eosinophils. We've seen all of that. And whether or not it's different or not, probably, you know, you need a really big population study. And I don't know that that's been done, but that's how we manage them.
Thanks, Marilyn. Let's go to Michelle, Jason, or maybe Molly about other things out there. I see people mentioning some anticoagulation or aspirin or hyperbaric oxygen. Anybody heard of any of those? Do we have any data that those are effective yet? I should ask. Michelle, you can go ahead.
Yeah, I'm not aware of any data that those are effective, but you know, I do like Marilyn was saying, whether we try inhalers. The other thing we're doing is referring some of our folks to pulmonary rehab. I think that helps. Dr. Elise Sheehan at my institution is heading up our post-COVID pulmonary clinic, and we see people that are 60 days out from their COVID infection that still have pulmonary symptoms, do a full battery of tests, and then refer a lot of those to pulmonary rehab. And they do have improvement in their symptomatology, and you know, their confidence and ability to be more active. And so I think that might be an option. Now that's not available for everybody because there may not be pulmonary rehab centers around, but that's one thing that we found to be helpful.
Thank you. Another question, speaking of what's available in your local area, you know, we don't all have access to MRIs or pulmonary rehab. And there's an interesting question from Marcia about tribal nations. And I think, Marilyn, you mentioned this about the Navajo population, and maybe Michelle, you would, working in New Mexico, you'd be able to comment on this at well. That the question is that tribal nations were hit particularly hard. Has anyone looked at the burden of long COVID in these populations? And then a separate question, what is available to those practicing in more rural environments? Michelle, you want to start?
Sure, yes, we've had a large population at UNM, Navajo and other Pueblo tribes. And so we have also offered some remote physical therapy. So besides the pulmonary rehab where you can't come to the center, we did have a program we were developing for remote pulmonary rehab. Now that requires, you know, an ability to either do it on your phone or have some internet access. But we're a large referral center, so we see a lot of the patients post-COVID from the tribal nations.
But what I can tell you that we did in Arizona, in Phoenix, which Michelle knows, is we had groups of residents and medical students and attendings that are Navajo that formed groups that go out to visit the patients, because most of them are taken care of by visiting nurse practitioners. Our biggest problem came with patients who didn't have electric and running water, and getting them the supplemental oxygen. If those that were able to survive, I think I showed at one of the talks in this meeting, our little video of the patients leaving. And in the beginning, it was all Native American. So we followed quite a lot of these patients. But I think access to care is an issue for them, and getting them the long-term care they're going to need, I still think remains up in the air.
Thanks for that. If we could just kind of come on a relative consensus of what we think is the basic workup that's available to primary care providers out there. What are the things that we really don't want to miss? Maybe Molly, sorry, I'll start with you. What do you want to do? I know that sometimes you bring up sleep studies as being an important thing that's sometimes missed, right?
Yes, that's true. I think if they're really just complaining of shortness of breath or cough, dyspnea on exertion, then usually as a pulmonary person, pulmonary function testing is pretty widely available, at least spirometry. So that should be a simple test to look for like obstructive disease like asthma or COPD, and then also look to see if there's any evidence that might suggest some interstitial lung disease that could be a result of COVID. Walking people and checking their oximetry is also a very affordable, cheap test that is widely available, and that's something else I would recommend doing. And in that test, you could also look to see if they get, unexplained tachycardia, other signs of dysautonomia. And then sleep studies, I think, are useful in people and are sort of as needed. So I think that's an important thing that a primary care doc should or can ask about is, how are you sleeping? Are you having lots of awakenings, gasping, snoring? Not that COVID is a cause of sleep apnea, but just that untreated sleep disordered breathing may exacerbate a lot of these daytime symptoms, especially the fatigue and possibly the brain fog and things like that. So something always that I think is important to address and optimize.
Jeff, anything to add that's sort of a simple way to assess autonomic nervous system?
Yeah, I think something we've implemented in our long COVID clinic, and I know a lot of other programs are doing the same, are not to only do orthostatic blood pressure measurements, but to do an active stand test. This involves essentially extending the orthostatic measurement through 10 minutes. And I think in doing this, you can elicit the presence of any symptoms that are triggered by standing upright over those 10 minutes, but also get a sense of the physiology, their hemodynamic physiology over this course of 10 minutes, looking for significant rises in heart rate or changes in blood pressure with this change in position. I think this has been especially important as autonomic testing, tilt table testing at our center has been flooded, and the waits for these tests are months long now. So this has been our strategy to help at least screen for clear evidence of heart rate increases that would be diagnostic of POTS, for instance. So I think this is something that can easily be done in most, if not all, primary care clinics. I think if possible, a 12-lead ECG, and again, if possible, a transthoracic echocardiogram can be helpful too.
Okay, thanks. We're running out of time, but I want to kind of bring it home with a really good question that came in from Carmel. Lots of times the primary care is going to send somebody for some degree of specialty testing, and it actually comes back as relatively normal. And then we're kind of stuck, and the patient is told that they have either nothing, or it's in their head, or they have some kind of functional disease. So I want to start with Sonak and just to talk about how we approach this situation, because it's becoming very common. And then, any other advice from the rest of the panel about what to do once we arrive there.
Yeah, I think this is such a crux of the issue for patients. And one of the things that I would add on a human level is when a physician or a clinician says that there is no detectable clinical issue, the impact that has on patients is it almost says to them that you're saying that they're making it up. And I know that that's not what a lot of times we're actually saying, but that's how the patient interprets it. And so it's very important to distinguish what you mean by we can't detect what the actual problem is from actually saying that it doesn't exist, and to reassure the patient that you fully believe that their symptoms are real and they exist. It's just the challenge we're facing right now of actually defining what is causing it. And just phrasing it that way and really reassuring the patients that you're listening to their symptoms and believing them goes a long way. Because I can tell you from the chats and a lot of the messages you might see on message boards, a lot of patients feel like they're being dismissed by their providers and that their symptoms aren't believed. And so as we're still struggling to come up with definitive solutions and explanations from this, the biggest thing I would say is that it's important for providers to really acknowledge the symptoms and acknowledge them as real, and work with the patient as we learn more about this to understand their symptoms and come up with treatments that might work for them.
Perfect. Thank you so much for that, Sonak. We're running short on time, so I'm going to ask the panelists just for final comments. Jason, I saw you're about to come off of mute there before we wrap up and end for the hour. Jason?
No, I was just going to second that, emphasize, of course, symptoms don't need to be proved. These people are having real breathing discomfort, and there are very real reasons to have breathing discomfort beyond just scarring in the lungs or something that someone could find on your x-ray. So I emphasize often to patients that actually we expect the workup that they've had before hasn't revealed anything, because we're finding that for most people, they're not having a disease that you can find on the x-ray, and even sometimes on the pulmonary function tests, but that doesn't mean they're not experiencing real breathing discomfort and have an injury after COVID. So I think partnering with patients, and as Jeff mentioned, observing them in your clinic, how they respond to movement when they feel their symptoms, how their symptoms manifest, helps you figure out how you can best treat them.
Thanks, Jason. Michelle, and then I'll go to Jeff and Molly.
Absolutely. I agree with everyone. What I've been telling some of my patients is, while your test is normal, that's great, but I do believe you have symptoms, and we're still learning together. And, I think that supporting them and listening and believing is really important for you to have a good working relationship. And I also say that, I'm involved in the Recover grant or the PASC study. And as soon as I learn something, you're going to be the first to know, and so as soon as I'm learning more things, I want to involve my patients that I've seen to say, hey, this is what we're finding. But hang in there, and there is a good chance that some of your symptoms are going to actually improve, but it's just going to take time.
Thanks, Michelle. Jeff?
Yeah, and I'd like to echo the points that were made, and I think Sanak really described it very well. I think early in this experience, I was screening for testing abnormalities, troponins, echoes, ECGs, and everything was coming up normal. Initially, I thought I was bringing good news that everything was normal, but then what I found was that clearly our patients were still in a lot of distress, and I think I learned that you had to continue to work with them. Of course, you do your due diligence to make sure you're not seeing any abnormalities on those tests. If you do, then you address those specific abnormalities. But then after you do the initial battery of tests, I think it's important to really, again, try to characterize the phenotype you're seeing in front of you, and working with the patient closely to try to figure out what works and what doesn't. I kind of describe it with my patients as a little dance where we try something, see if it works. If it doesn't, then we'll try something else, because we're kind of learning together. And I do think it's important just to really dig deep into figuring out what the physiology driving their particular symptoms is, because I think it will be different with each patient.
Thanks, Jeff. Molly, and then I'll give you the final word, Marilyn.
I agree basically with what everyone is saying, that it is very common that we don't find anything, and then that's frustrating for the patient, but it is important to emphasize your symptoms are real, and we're going to keep working with you and trying to sort of figure out what is uniquely your symptom and how we can fix it. And, I'm learning more and more about the dysautonomia and the effects of the postural orthostatic hypotension on dyspnea symptom. And I think that there are some potential, I don't want to say breakthroughs, but deeper understanding of phenomenon that we've kind of maybe overlooked for a long time, and we have ways that we're going to build toward helping people, but appreciating that at this time it is frustrating when we don't have a clear answer or a clear treatment.
Thanks, Molly. So Marilyn, bring us home. Where are we headed?
I think the future is good if we can keep doing the work that we need to do. And thank you for getting involved and staying in with PASC. And I've noticed in the chat all of the comments from people who say, there should be other physicians listening to this. And so I would encourage, since it's recorded, that you all share this, because I do believe that we haven't done probably as much as we need to do to get out to the communities about the realness of long COVID. And that, a lot of these patients just think they're crazy. And they're told there's nothing we can find. There's nothing you can find. And so referrals to centers like are represented on the call, I think are also important. The last plug, of course, is that I think we're going to get some answers about whether or not there's a vasculopathy and if that requires long-term management. I think we just have to be patient while we do those studies. But I think we're going to get a lot of answers in the next year or so, which will help us.
Thank you so much. And thanks to the panelists for your time, Jason, Marilyn, Michelle, Jeff, and Molly and Sonak. Really great discussion. And I would just call to action those that are here. There's a lot of people that aren't here that probably need to hear this more than you do, but please help spread the word. We're going to be here every month for the next couple of years. Let me pass it over to Bruce to finish up.
Thanks, Christian. And thanks again to all the panelists. And in particular, thanks to the participants for spending an hour with us. You're the reason we're showing up, and Really appreciate all the comments and resources shared in the chat and the Q&A. And this is an ongoing discussion and learning series. Just want to remind everyone, we actually are going to be launching a new quarterly asynchronous web-based learning series that's actually synthesizing the learnings from these sessions and some other related sessions. They'll be available through the website, and we'll share the link to the website that supports this initiative. And that'll be coming out around March 21st and available until about the 18th of April. And then every 3 months, a new set of modules will become available summarizing the learnings of the prior quarter. So keep a lookout for that. We'll be mentioning it in future sessions. Also want to remind everyone, next month, Jeff Su, who's one of our panelists today, is going to be talking about autonomic and cardiac manifestations of post-COVID conditions. So please join us then. And again, please take advantage of the CME, give us your feedback and help us plan for future sessions. Take care. Thanks, everyone. See you in a month.